Welcome back, guys. So we were talking about the burden of disease, and we are trying to look at how diabetes is affecting so many people and the communities. And I just like Onesmus to take us from where he had left. I think he was on point number 2. So let him continue from there.
Yeah, thank you, Daktari. We were really looking at the global, basically the disease burden.
Yeah.
And laying some of the few questions that could paint a picture. And one of the things we're asking is, what about, we were talking about how this disease, how diabetes, sometimes we have people out there in the community who are not diagnosed with this disease. So what are some of the impacts, what are some of the effects, or some of the things that result out of that?
Yes.
And the question was, this disease, because it causes complications and other things, other problems result from it. Some people are out there and they don't know their status about diabetes. Whether their blood sugar is in controllable levels or in the right levels or not. So this would cause, or sometimes this results in some deaths which could not easily be documented. What was the real cause of death? And when you look back, you realize there was an underlying problem. There is a probable underlying problem which might have been diabetes, though not the immediate cause of death. So that is one thing. The other question that we also, asking ourselves and posing is, there are still people there out there in the community. They have this disease, but then the follow-up in the community, the follow-up in the clinic, is also not very good. It's, for lack of a better word, we say it's poor, follow-up. They're given clinic follow-up. They are not very effective, or they are not, very
so
thorough.
So those are the people who are not adherent.
Yes, they are not adherent to the clinic. So poor clinic follow-up. And some of these clinic follow-ups are also not well scheduled. Maybe that could be on the health provider aspect. But we are saying, whether the health provider or whether the patient, all of us as a community and as a people, we need to know that follow-up is also important. Adherence to treatment, adherence to clinics. We need to protect and prevent our people and the community from basically getting this disease, so that we can reduce all these burden that you're talking about, and these effects that you're talking about, be they financial, be they social, be they stigmatizing, issues and mentalities in the mind, and even fears into the coming generations. We already said as we began that there is a family history or a family predisposition. Yes, there's a genetic factor in terms of the causation of the diabetes. So the question is, if then I have a great-grandfather or a grandfather or a father, in that sense, who had diabetes, is it likely that I'm also living with it? The issue is we need to have this checked and tested, and have them started on treatment. And I want to believe we'll continue tackling especially matters about diagnosis, and all that.
And I think this is a very important public health issue that you're bringing, in that the person who has diabetes is not the only one being affected.
Exactly.
It's affecting almost the whole community.
Yes, affecting the whole community.
Yeah, and this burden is really great. So let's just move on to the symptoms, because we need to know, does somebody need to wait for the symptoms to be tested? What advice would you give, and what symptoms would show that someone has diabetes?
All right. What I'll start by saying is, the diabetes, what we call diabetes mellitus, has symptoms. But maybe as a starting point, we would also say that you also have incidental findings. Sometimes you have a patient or someone just comes into the health facility and you are coming for other problems, or other, you are thinking of, other problems, other health problems. Then peradventure, you just decide, let me screen for, diabetes. So sometimes it's actually asymptomatic. There are those incidental findings. They are few, but they are there. But then going a little bit deeper into the symptoms of diabetes, would say that they are actually what we call specific symptoms that really would lead you directly, and as the person, as the patient comes in the health facility and they are saying their symptoms, it's really painting into your picture of diabetes. Those are called specific symptoms. But we also have non-specificity in terms of symptomatology, in terms of the presentation of the patient. Now, earlier on,
I think we need the specific symptoms.
Right. Right. Earlier on, we said we have type 1 and you have type 2 diabetes, among as many others that we find in special groups. Now, some of the symptoms that cut across, whether it's type 1, or type 2, well, largely, is that one of them is that someone all of a sudden, or it was not there before, but they begin feeling thirsty. They want intake of water excessively more than they usually do. It's not out of heavy activity, not out of a lot of exercise or a lot of work, but they are feeling more thirsty. So that's one. The other thing that we usually see is voracious. Well, maybe that's a big one, but appetite, the appetite really goes, the appetite really goes very high. The individual feels they really want to eat. And the issue is they already have glucose in circulation, but it's not being, the cells are not able to access it. So it's suffering in abundance.
Starvation.
So the cells are starving. There's abundance, but yet they're suffering. So someone wants to eat more. The other issue is there's an urge to go for a short call many more times. Because of course there's also intake of a lot of water, a lot of fluids,
and also the glucose being lost in the urine.
And also the glucose being lost in the urine. These are also factors. The other issue we also find is that weight loss. Some people begin to lose weight because the cells are not able to gain, so they are beginning to eating up this glucose in the circulation, but they are beginning to eat up whatever it's stored, whether it's in the fat or it's in the muscle. It's beginning to, so weight loss becomes an issue. Well, I know you mentioned probably this, Dr., but in children also we find what we call failure to thrive. They are not adding up weight. When you look at that purple book, and I want to believe that we still have those books, and we maternal and child health book, booklet, and I still want to believe that out there we are still using it because they're very important and having children checked. Anyway, but when you look at that book and you look at the weight, that weight is not on the road to health. It's
actually flattening.
It's flattening, and it's below the yellow line, or sometimes even going towards the red. So weight loss and failure to thrive or inadequate weight gain than what is expected are some of the other things that begin seeing. Other symptoms will basically also be relevant with the complications. So that if this disease has affected, and this is also common, whereby you find someone presenting with a symptom, they are not able to, their vision has been affected, not able to see well. They have some blurred vision. Some of them come up with wounds on the feet or different body parts, which are not healing very well. So these are issues that we are seeing.
I think those are good. I think those are enough. Maybe we can go to the diagnosis. Sami, maybe you could mention how the diagnosis is made.
Sure. Diagnosis is quite important for this, because that is actually how you will just know that someone has delayed levels of sugar. It's a simple test that is usually done by a health professional. A nurse, a clinician, a doctor can do it probably when someone just visits and requests for that. It's cheap and easy to do test. It's not a test that, kind of test that one could be worried about. Once the doctor clicks your finger and takes blood sample and lands the test, he will give you a range of your blood sugar. The measure of your blood sugar again is the normal range. The normal range usually is between 3.5 to 7 in most instances. 3.5, around 4 being the fasting blood sugar. That is the lowest. That is when we have not taken food for about 6 to 8 hours. That is usually called the fasting blood sugars. Then we have the normal blood sugar. That is, we call it postprandial blood sugar, or else random blood sugar, which can be taken at any time. It still falls within that range of 5 to 6, 7. That is within normal range. But when we have, when levels are going beyond 7 towards 11, then we have a condition called glucose intolerance. This state is where one is known, or else they know that they are at risk of getting diabetes. At this point of glucose intolerance or impaired glucose tolerance is a critical stage, especially for type 2 diabetes, because it's a time that one can turn it around. If you really respond to doctor's advice, change your lifestyle, improve on your diet, then you can turn it around. But when you just continue with normal life as nothing happened, with that kind of a reading of a sugar, random blood sugar, then most likely you may someone may tip over to diabetic state. Now, above a random sugar of 11 millimole, that is purely diabetes, and that is hyperglycemia. And probably that is when one is told, probably you could be diabetic. Could we repeat the test again? Could we monitor your sugars on this schedule? Could we adjust your lifestyle? Could we probably do more investigations in your body, including urine tests and other tests, just to check on how the last 3 months you control the sugars, called HbA1c, and so and so forth, including ophthalmic evaluations, cardiac evaluations, blood pressure monitoring, and so and so forth. Yes.
Okay. Yeah. So you've even mentioned some of those investigations that would be done that are extra for someone who has diabetes.
Sure.
So let's say one person has been told they have glucose in sugar. They have glucose in urine. Their sugars are above. Maybe they have a sugar of 30 millimoles per liter. Yeah. So at that point, would you tell this person they have diabetes, or would you have to do any other tests?
What we are saying is, once this blood sugar level has been proved to be, what Daktari is talking about, random blood sugar of more than 11.1 millimoles per liter, the figures above that, 13, 14, 15 and the like, as you say, and then you also have some of this glucose being excreted in urine.
Yes.
At that point, we'll be making a diagnosis.
Yes.
We'll be saying that now this is diabetes mellitus. There is, of course, what we would want to classify whether this is going to be type 1 or it's going to be type 2, depending on the presentation, and that's a little bit more technical on the health provider aspect, but we'll be making a diagnosis of diabetes mellitus. We could also do supportive tests, to see of how high this blood sugar has been for a period of time. Like I already mentioned about, there is this test you can be able to do that tells us about 3-4 months down the line, how was the blood sugar. So, and finally we are saying we have made a diagnosis, so we need to treat this
patient. Yeah. So what would be the first step that we'll take for this patient, or what are the management ways? How can we manage these patients who have diabetes?
I'll probably say diabetes is multidisciplinary. It requires a multidisciplinary approach in terms of management.
Yes.
It's not a one-man show. It's not about the doctor making the diagnosis and giving a package of a few tablets to the patient and just go home and come after 2 weeks or given a specific a duration of time. No, we are saying this has to be multidisciplinary, and there are key players. By the time we're making the diagnosis of diabetes, we have key players. Number one is the health provider, who is going to be the person who is making the diagnosis, or the doctor or the clinician at that point who's making the diagnosis. Number two player is the patient. The patient has to understand, like we said from the beginning, that this is a chronic disease. This is a disease that the objective of management and treatment is not necessarily to cure it, but to manage. We are not eradicating the glucose from the body. We want that glucose level to be at optimal levels. So we are not removing it. We want it there, but we want at optimal level. So the objective here is control. So the patient has to understand here we are looking at control. Now the other team players in this is other health providers who are also going to be key in terms of prevention of complications. So we'll need to have at some point, but basically we also need a nurse in play of this. We will probably need a dentist, we need an ophthalmologist, and of course a lab technologist, all these healthcare workers in a hospital, and a nutritionist, very in a big way, to be able to manage this particular patient. And where we have very good systems, a patient will basically pass through all that particular system and have them be taught. We even have a point whereby the patient has to be taught about the disease and be told this is what is expected and this is what happens, and teaching them and training them about also what are some of the complications.
So maybe what kind of medications would they be given to
the patient? Now, in terms of the treatment of the patient, we'll need to have what we call specific treatment, and there's adjunct treatment or supportive therapy. Now, if we talk about specific treatment, which would be the healthcare worker doing that, classify the disease. Is it type 1, type 2, or any other special group or the special type of diabetes you're talking about? So if it is type 1, then you'll have this patient having to be dependent on insulin. Remember we said that this type 1 disease, the patient is not producing any insulin. So they have to be insulin dependent.
And it's going to be lifelong.
And it's going to be lifelong. It's going to be lifelong. It's injectable. So we have to train our patient on that and really comfort and support them into that. Now, when you come to type 2, we'll have to introduce type 2. We say there's insulin resistance or inadequacy where there is producing little amount of insulin. So therefore, there are medications or tablets which you can use. Some of these will help, the gland, the pancreas, to be able to, help the pancreas have production of insulin. And also this medication also help in terms of reducing the resistance at the tissue or cellular level. So there are tablets to do with that. At some point or sometimes we also include insulin into it as part of this therapy. So at least in type 2 we'll have some tablets in it most of the times as we start, and then monitor, because what we also said in terms of the development of the disease, there are varying but progressive instances and progressive issues with the gland called the pancreas. So at some point we need to make other decisions to move along. In terms of the non-specifics, Daktari, because this was very important, and this is where also the patient comes in, is that issues to do with management of weight, we need to bring it in a very good way, so that we also don't discourage our patients so much, but we also need to begin showing them that reduction of weight is also going to be important.
Yes, is a very high risk factor.
It's a very high risk factor. This is a very high risk factor. So how do we manage this? So bringing in physical activity, and this physical activity has to be moderated. It has to be at tolerable levels, because our patients, some of them are old, they're not able to do a lot of heavy activity, but we have to moderate. We have to tailor that activity into our patient. The other thing we also said is that in terms of lifestyle modification, Dr. talked about issues to do with our intake and the kind of lifestyle we live. So is it possible to some few days to leave the carbohydrate and basically walk, and take a matatu? Is it possible to jog in the morning? Is it possible to walk to the shop and buy what we are buying instead of driving there? So
and let me just say something on that. With the WHO, they say that for an adult, you need to do 30 minutes of intense, moderate to intense exercise in a week, maybe 5 times. So that's something that you're really just trying to make sure that this person is getting themselves to do more physical activity.
To do more physical activity. And if this is part of their daily activity, then we need to know that that is not counted as exercise. We have to top it up. We have to top it up and be able to add on that. And probably the other issues that also requires, which is part of supportive therapy, which is advice also given to patient, or also give to our patient, is that let's also know that besides controlling the blood sugar levels to the optimal levels, we also have a time of preventing complications. So that will go along with scheduled clinic follow-ups, will go along with doing this particular test, and when you're advised to go see a specialist and all that. And basically this is supportive therapy to the patient.
You've mentioned complications, so we're going to look at those complications, but before we do that, there's an issue. We've said patients can be given insulin, and you know that insulin makes the blood sugar come down. So it would be important for people to understand what kind of symptoms they'd be having if the sugar levels go below the normal.
Thank you. Actually, in my practice, I've seen this in the emergency department. It happens especially in the morning for the elderly patients who are on insulin, and probably they may be sick at one point, and they didn't eat well probably the previous day, and they took their dose of insulin. In the morning, the caretaker just reports the patient was dizzy, came up, could not express themselves well, there was profusely sweating, and what hit their mind is that this patient is diabetic, so the sugar is sky high. You know what they do? They just give a jab. They inject them another dose of insulin.
That's very sad.
It's so unfortunate because it's just from a point of ignorance. Now, signs of hypoglycemia. Hypoglycemia is a medical emergency. actually is more dangerous than hypoglycemia.
And I think he mentioned some patients even sudden death can occur.
Exactly.
Or somebody faints and nobody knows that it's a low sugar.
Patients can die, or someone can die of hypoglycemia so easily. So these are the key things to know, especially when at home.
Yes.
And most likely it happens to patients who are on insulin.
Yes.
And probably tablets that lower the blood sugar levels. Yes. One, it's let me talk to the viewer.
Yeah.
One is excessive sweating. Excessive sweating. If you note that a patient or a diabetic patient is excessively sweating, kindly know that that could be most likely the sugars is abnormally low.
Yes.
Number two is confusion. The patient becomes confused. They cannot express themselves. And probably they have tremors all over the body. They kind of, become very confused. The third one is when this patient feels so much hunger. They complain of hunger.
Exactly.
And they feel like they want just to take something to eat. And the other one, which can happen when the symptoms persist, is passing out or going into a coma. These key things are serious on hypoglycemia, and they can cause serious mental damage, brain damage from hypoglycemia issues. So when you see that, what do you do at home? When you see that, what do you do at home? You should provide this patient with something to eat, if they can eat. If they cannot eat, give them something to chew, sweets, something sweet to chew, probably a sweet, probably sugar. Let them chew in the mouth, and don't give them insulin. Don't give them insulin at that point. Then call emergency medical responders or take them to the hospital immediately. They will be attended to.
Yes.
Thank you.
Awesome. So that was good for our viewers to understand, so that they can learn. And if you see maybe somebody who has fainted on the road, I think one of the first things you can do is, maybe open up, lift their legs and give them some glucose, because you don't know what made them faint.
That could save a life.
Yeah. So let's just highlight some of the complications of diabetes. I think especially one where a patient can have a role to play in terms of preventing it. We know that these patients are at a very high risk of getting infection. You mentioned that they even undergo amputation. So I think let's just mention something about the foot care for these patients, because I can see when we're out of time. Yeah.
All right. Thank you, Daktari. In terms of complications, there are many, number one, classifications of complications, and there are many complications. We may not have time to exhaust all that.
Yes.
But like you said, some of them that the patient can have, we'll probably classify them into one simple classification, which you would call acute and chronic, besides other classifications of these complications. We would have some acute complications, like Dr. has talked about low blood sugar, what we call hypoglycemia, that could actually occur. Diabetes could also have, infections could also come in, where someone is diabetic, and then that they have a wound, on the toe or foot or something like that, and then that gets, infected. These are acute things, and they're going to be treated in a short period of time, and then they are going to resolve, hopefully, if we use that word. But then there are also chronic issues, or there are long-term problems or complications that can result. Some of the, if we put it just in summary, because sugar flows in basically all body organs and all body parts, diabetes complications can affect any body part. Yeah. But then some of the ones that you seriously have issues with them, number one is to do with the feet, and number two, we are saying that this could also lead to blindness, because it could also affect the eyes, the retina. Yes, the retina. It could also affect the heart, and bring in other problems like blood pressure, heart attack, and sudden death, things like that. And then we're also saying that it could also affect the kidneys, and these are major organs. Now, and the brain, could also be, part of it. Now, when you talk about probably the feet, because these are some of the things that we would also encourage even our viewers to take part or participate in terms of prevention of this complication, is that the feet being part of the extremities, or the lower extremity, and you also see a problem there is the reduced blood flow, because the vessels have been affected, the nerves have been affected. It's possible to get foot problems. Now, we would always advise our patient that take care of their foot. And what are some of the ways to take care of the foot? One, anytime in the house, make sure that you have, a certain footwear. Just walk barefooted in the house. It's not recommended.
But I think you haven't really made it known exactly why the foot.
Why the foot?
Yes.
All right.
Maybe the issue of the nerves. You should bring it out more.
The diabetes, one of the other classification which we really don't have time to go through is where we talk about microvascular and macrovascular, where the vessels are affected.
Yes.
Basically in simple language, the vessels are affected, the blood vessels are affected.
The arteries and the veins.
The arteries and the veins.
Yes.
And remember that these arteries and veins, they also supply or drain nerves. Because you have a nerve that's going to be supplied by a capillary that's going to need blood supply. Okay. So once this is affected, we have the nerves dying off. We have you have the nerves dying off, so the sensation on the feet reduces.
Yes.
So it's possible for someone to get a wound or an injury and they don't know. At times is we find patients just coming onto the health facility, they have a wound and it's an incidental finding. They even don't know that there was actually a problem there. So we are saying as part of prevention of this, it is important that you make sure we wear footwear, whether it's in the house or outside.
And I think you can look at the camera as you give this.
And yes, our viewers,
give the advice.
This footwear, let's make sure that it's footwear that is also not part of the problem. Because some of the footwear that we would also do can become part of the problem. Let it not be so tight, be so fitting that actually it's compressing or pressing on the fifth digit or on the big toe. Because if that happens, then we'll have a wound that develops there.
Yes.
And that will be a problem also to manage. So let it be, have some space inside, let it be a bit flexible. Number two thing also about the footwear that we also want to bring out is that let it not be a source of injury in the terms that it is also a high heel. Right? Because high heels also have a chance of someone, in case of a loss of balance or any effect towards that, they can easily fall. And when one falls again, it will contribute to an injury. That also calls for us to be able to manage these type of injuries or these types of problems. So footwear is important. Let's make sure that in between the toes that we actually dry them, prevent cracks, fungal infection in between there, which is also going to be problematic in terms of management. Well, other things that we also need to besides the foot that we also need to take care in terms of complications, when it is, we have said these. And probably, if Dr. you allow me, let me emphasize or repeat for purpose of...
to cut you short.
Yes, for purpose of emphasis. Let's be also regular on scheduled follow-ups. I think this cannot be overemphasized because this is where we are going to refer our patients to the dentist, the ophthalmologist, do various tests and be able to check that our patient is doing very well. Yes.
Yeah, so even as we come to our end of the show, I think we'd like to hear a parting shot from Mr. Sami. You can look at the camera for about 30 seconds and give your parting shot. Thank you, Dr.
Viewers and listeners, as you have heard, the discussion has been quite expository on matters diabetes. It is quite essential that we know that it's a burden, it is a reality within our community and in the society that diabetes is with us, and we can together work towards achieving controlling it. The work that we have is to achieve to control it.
Thank you so much for that advice. So our viewers, we've come and you've heard from our experts. We've been able to talk about diabetes. We've looked at what is causing the rise of diabetes in our people. And basically, we've seen that excessive weight gain is one of the factors that leads to diabetes and having a family history of diabetes. So we're saying try to prevent yourself from getting it by eating food in moderation, eating junk food in moderation. And also, if one has been diagnosed with diabetes, it's not the end of life. They should not live in fear. Adhere to what your doctor is telling you. I'm going to leave you with this verse from Deuteronomy chapter 31, verse 8, which says, "It is the Lord who goes before you. He will be with you. He will not leave you or forsake you, and do not fear or be dismayed." So anyone with diabetes can live a long and a healthy life. And we are so glad that you could join us. We are just going to end there, and we hope that you're going to join us even next time.